Peroral endoscopic two-way tunneling, and lumen restoration for complete esophageal obstruction. Complete esophageal obstruction, more than 3 cm in length, can be challenging for endoscopic and surgical interventions. Postcricoid location of the stricture makes the situation more complex as there is less room for maneuver with the endoscope. Peroral tunneling, utilizing the third space techniques, can establish continuity in such cases. A 52-year-old gentleman presented with aphasia after undergoing laryngectomy for recurrent carcinoma larynx following radiation therapy. He had a pharyngocutaneous fistula in the postoperative period. Feeding was being done through a percutaneous gastrostomy tube which was placed prior to surgery. Upper gastrointestinal endoscopy done at another hospital showed a blind dent in the upper esophagus and imaging suggested a length of more than 3 cm. He was referred to our unit for further management. Upper GI endoscopy done showed that there was a blind dent in the postcricoid region with complete obstruction of the lumen. His case was discussed in the multidisciplinary team meeting and the options were discussed. Peroral endoscopic tunneling procedure was suggested. The procedure was done under general anesthesia with the patient in supine position, 2 endoscopies, and under fluoroscopic guidance. These were the electrosurgical settings used. Upper GI endoscopy done showed the same findings. After this, the PEG tube was removed and tract dilated using a balloon to 12 mm. The endoscope was then passed through the tract into his stomach and across the GE junction into esophagus. The completely obstructed lumen of esophagus was noticed. No transillumination was seen. Keeping both the endoscopes close to the stricture, the distance was approximately 4.3 cm. The endoscopes were then removed and transparent cap attached to tip. From the retrograde endoscope, a mucous incision was made at 7 o'clock position, approximately 4 to 5 cm from the stricture, after submucosal injection with diluted indigo carbon. There was intense scarring, and with careful dissection, the submucosa was entered. The tunnel was extended up, taking care not to damage the muscle layer. Inspection of the lumen after exiting the tunnel showed that the dissection was crossing the stricture. Endoscopy from the oral side showed a submucosal bleb at the site of stricture. This was incised at 5 o'clock position, which was in line with the retrograde tunnel. Dissection was done through the scarred submucosa. At this point, transillumination was noticed, suggesting that the tunnels were close to each other. Further dissection led to entry into the retrograde tunnel. After this, a guide wire was passed into the esophageal lumen from the oral side. A 10 cm long, fully covered cervical type of stent was placed. This was monitored under fluoroscopy and endoscopy. Endoscopy after placement of stent showed that the proximal end was just beyond the cricopharynx. Contrast instilled through the stent was flowing freely into the distal esophagus. Next day, oral contrast study showed free flow of dye into the distal esophagus. Patient was started on liquid diet, which was enhanced to semi-solid diet. He was discharged on third day after the procedure. Self-expanding metallic stent was removed after 6 weeks. Endoscopy after stent removal showed a patent lumen with ulcerations and scarring. On follow-up, he required 4 sessions of dilation. Triamcinolone was injected to the area after dilation in 3 of the sessions. No dilation was required in the last 1 year. Patient has gained about 10 kg of weight. Complete esophageal obstruction in the postcricoid region can occur as a rare complication after surgical and radiation treatment for laryngeal malignancy. Peroral tunneling across the stricture using third space techniques followed by self-expanding stent placement can restore continuity of lumen. After stent removal, these patients require repeated dilations.